So these are all kids admitted in our institute, NRS Kolkata. So this is a 1.5-year-old boy. Body weight is 18 kgs, BMI 20.9. He had delayed motor milestones, hypotonia, and of course hyperphagia. So hyperphagia was common to all of them. A 4-year-old again had similar presentation with cryptorchism on one side, and this is a 16-year-old girl. She already had type 2 diabetes, she had secondary amenorrhea, along with poor scholastic performance. So Prader-Willi has a very classic faces, narrow face or narrow bifrontal diameter, typical almond-shaped eyes, thin upper lip, downturned corners of the mouth. This apart, they have very characteristic other systemic manifestations as well, like in perinatal period hypotonia leading to decreased fetal movement. They could have breech presentation. In infancy, there are feeding problems. They are not obese from birth. Initially, they have feeding problems. Later on, they start having hyperphagia, and they could be having temperature instability. Early childhood, the hyperphagia sets in, along with intellectual disabilities, temper tantrums, etc. So we do have some clinical diagnostic criteria for Prader-Willi, and depending on the age, we have to count how many major and minor criteria they have fulfilling. But again, we have to rely on genetics for Prader-Willi syndrome diagnosis. It is if we look at the root cause, it is absence or non-functioning of a very critical region on the paternal chromosome 15. So as we know, all of us have a maternal allele as well as a paternal allele for every gene. And in Prader-Willi, the paternal allele of this particular segment is not working. So this could be either due to deletion of the paternal allele itself, which accounts for 70% of the cases. It could be due to maternal uniparental dystonia, that is both the copies are coming from the mother, which accounts for around 1/4 of the cases, and very rarely it could be due to problems in the imprinting center itself, causing some problems with imprinting, maternal imprinting. So if we are doing karyotyping or FISH, the only thing we can diagnose is the deletion, that too if it is a large one involving that segment like this. But we would be missing around 1/4 of the cases of Prader-Willi if we are doing only karyotyping or FISH. So for that, we need to do something known as methylation sensitive MLPA. So this detects the amount of methylation in the child, and so since both the copies are coming from the mother, we expect 100% methylation for Prader-Willi, even if it is paternal deletion or if it is uniparental dystonia due to both copies coming from the mother. In contrast, a normal individual would be having 50% methylation. So if we are doing MS-MLPA, we can detect both deletion as well as uniparental disomy. So this is the result of the second child who indeed have maternal allele 100% methylation, suggesting Prader-Willi syndrome. So if we look at the algorithmic approach towards genetic testing for Prader-Willi, the first test should be methylation sensitive MLPA, not karyotyping, not FISH. Now if we detect abnormal methylation, the next step should be FISH or a microarray to detect if it is deletion, or if that is normal, then it would indicate a maternal uniparental disomy, and then rarer tests like DNA polymorphism test to understand if it is the imprinting center defect. So coming to the history and clinical examination, so apart from anthropometry, the history of hyperphagia, the developmental milestones, we do have some validated questionnaires to assess hyperphagia. Only the mother's history is not enough. We need to put these questions to understand if it is significant enough. In management, infancy, the focus should be on ensuring nutrition because they have feeding problem in infancy, and growth monitoring, adrenal cortex functioning. In childhood, in contrast, we should take steps to control the hyperphagia, growth hormone therapy, pubertal induction at time, and reassessment of adrenal function. In adulthood, more of occupational therapy and lifestyle changes. So growth hormone in Prader-Willi not only normalizes height, but also increases the lean body mass, their activity levels, and reduces fat levels, and possibly could benefit their motor development as well. It should be started early before the onset of obesity, and there is no need of any IGF-1 or growth hormone testing for that. The dose is usually lesser than what we give to growth hormone deficient children, and this is because of multiple concerns about sudden deaths that have been reported for Prader-Willi syndrome on growth hormone. The exact etiology we do not know. Whether growth hormone is responsible, that also we do not know. Sleep apnea, hypocortisolemia, these have been proposed. So we need to exert some caution before we start growth hormone in Prader-Willi. We do an OGTT, we do a polysomnography, we look for scoliosis, hypocortisolism, etc. and manage these first before we go to give growth hormone. For hypogonadism, cryptorchism is common, so early treatment within the first 6 months. HCG, if not working, then maybe orchidopexy. Puberty, They can enter puberty, but usually there is pubertal arrest, and they do need HCG or testosterone for males and estrogen and progesterone as for any other hypogonadal cases for females. For obesity, there is a lot of data now coming about GLP-1 RAs in syndromic obesity, especially Prader-Willi syndrome, which showed BMI, HbA1c as well as improvement in satiety levels, also with oral semaglutide and multiple other agents that have been tried. So for these 3 kids, the first kid, we started him on HCG for cryptorchidism. The child with Prader-Willi, we have planned him for growth hormone, is undergoing sleep study now. And the lady, she is already on having type 2 diabetes. She has received growth hormone and we are planning GLP-1 RA for her. Coming to different presentations of Bardet-Biedl and adult obese diabetes visually challenged. Both of these are spot diagnosis. There is no need to discuss also. And this is the classic retinal presentation as we know. So Bardet-Biedl can be due to affection of multiple genes involved in cilia. And this defective cilia, why it causes obesity is because it has a role in hypothalamic nuclei maturation and migration of the POMC neurons. This apart, there is also leptin resistance, all of which could cause to Bardet-Biedl. Again, we have clinical diagnostic criteria, and apart from night blindness, it's important to identify they can have hypertension, they can have renal anomalies and needs periodic ultrasound and renal function monitoring. And these can be identified and prenatal ultrasound as well, polydactyly as well as renal anomalies. Thus, there is a room for genetic counseling. So again, management, apart from hypogonadism, we know apart from providing them gonadal therapy, they can have some other anatomical problems also because of their ciliopathy and they are mostly infertile. So yearly monitoring. Obesity management, again environmental modification most important, but high protein diet should be avoided because they have a risk for hypertension and renal problems. And anti-obesity pharmacotherapy, we have data with setmelanotide. It is FDA approved now for Bardet-Biedl syndrome in patients above 6 years of age. GLP-1 RAs have not been extensively studied in Bardet-Biedl, but may not be as effective. They have shown poor response to bariatric surgery. This is, we all know, pseudohypopara, they can have hypocalcemia, seizures, Albright's hereditary osteodystrophy, and this short fourth metacarpal. Typical phases of Carpenter's syndrome, Cohen's syndrome, we need to identify. And the most recent one, the Rohat syndrome, in which they have very sudden onset of hypothalamic dysfunction and a very high incidence of cardiorespiratory arrest. So this is another new entity. They have high risk of sudden death because of respiratory manifestations, autonomic dysregulation and hypothalamic dysfunction, which we need to monitor. So I tried to find out what happened to Lokman, and unfortunately I found that he actually died while choking while being fed on a Sunday. So in news media they reported is that it has Prader-Willi syndrome, but I beg to differ. 8-month-old, such obesity, choking, I think it could be something else, maybe some monogenic obesity which were missed at that time. So we do have some light at the end of this tunnel, at least for Prader-Willi. We have growth hormone, we have GLP-1 RAs and timely treatment of hypogonadism. We also have recombinant leptin for the monogenic obesity and setmelanotide for many of these diseases. So monogenic and pleiotropic syndromes are multiple which could cause genetic obesity in children. For Prader-Willi, MSMLPA and not karyotyping is the first-line genetic test. Bardet-Biedl is mostly a clinical diagnosis. We could do next-generation sequencing for confirmation. Growth hormone, hypergonadism and hyperphagia correction are the cornerstones of therapy in Prader-Willi. Of course, supportive care is still what we can offer to patients with Bardet-Biedl syndrome. Setmelanotide is effective but not available in India and very costly. And there is a promising role of GLP-1 RAs in all these diseases. So all of us are familiar with this meme that obesity does not run in families. It does that the families do not run, but we now know that it's not true. Obesity does run in families, but thankfully, although it is in their genes, it is in their destiny, we can do something for them, unlike some more bigger disasters for which we cannot really do something. Thank you so much.